Welcome to another episode of Progress, Potential, and Possibilities, discussions with fascinating people designing a better tomorrow for all of us. I'm your host, Ira Pastor.
Welcome, everybody, again to another episode of our show, bringing you today another really awesome guest. Today, we have the honor of being joined by Dr. Jerome Adams, Presidential Fellow, Executive Director of Purdue's Health Equity Initiatives, and Distinguished Professor of Practice in both the departments of Pharmacy Practice and Public Health. As the 20th United States Surgeon General and a prior member of the President's Coronavirus Task Force, Dr. Adams has been at the forefront of America's most pressing health challenges and is a regular communicator. You no doubt seen him on TV, radio, of course, in print. He is an expert not just on science, but on communicating science to the public and making relevant to various audiences. Dr. Adams originally was trained and is licensed as an anesthesiologist. He also has a master's degree in public health, and prior to becoming Surgeon General, ran Indiana's State Department of Health, where he managed a $350 million budget and over 1,000 employees, led Indiana's response to Ebola, to Zika, to various HIV crises, and also was involved in the state legislature and the governor's initiatives, legalized syringe service programs in the state, also prioritizing various programs on infant mortality. And then as Surgeon General, he was the operational head of the 6,000 person Public Health Service Commission Corps, oversaw not just the country's pandemic response, but he was involved in 3 back-to-back category hurricane, 5 events, in addition to his work in COVID and the hurricanes. No doubt he's been involved in partnering with and assisting various organizations on themes ranging from the opioid epidemic, maternal health, the rising rates of chronic disease and suicide in the country, as well as an interesting theme about how businesses can ultimately become better stewards and stakeholders in the public health equation. His new book, Crisis and Chaos, Lessons from the Front Lines of the War Against COVID-19, recently came out October 24th of 2023, available on major booksellers. We're honored to have him with us. Dr. Jerome Adams, thank you so much for taking the time out of your schedule to talk for a little bit today.
Hey, thank you so much for having us. You got my mother's version of the introduction, but I really do appreciate it because I think it drives home one of the major points that we need to remember, and that is that public health is so much more than just COVID. And everyone is so caught up in the back and forth arguments over the pandemic response and over COVID vaccines and over masking that we lose sight of the fact that public health is what allows us to have healthy food to eat. It's what allows us to have air to breathe that is safe. It's what allows us to take a drink of water out of the faucet and not worry about whether or not we're going to die from or get horribly sick from that water. And that's what I try to help people understand, is that we need public health. We need good public health infrastructure. And we need to learn the lessons from COVID, which I talk about in my book. But we need to also move past these fights, in many cases political and ideological fights over COVID that are hurting public health.
Absolutely. I mean, most definitely. You're starting out, before we get into obviously everything you were involved in, during your time as Surgeon General, I'd love to start off sort of at the beginning because, I very much enjoyed the book and I was really, impressed. You were very open and sort of sharing about sort of the many healthcare struggles faced by your own family. You talk about your wife's battle with melanoma, your brother's opioid addiction. You talk about your mother's stroke and your own, issues with high blood pressure, diabetes. But the story really starts off really at the intersection of asthma, which you developed as a youth, and then a theme we'll be getting into, the social determinants of health. Growing up in this poor rural community in Southern Maryland. Take us back to the beginning a bit, because I'd love to hear sort of the origins of this amazing journey you've been on.
Well, it's interesting because, again, people recognize me as the Surgeon General, but I start off the book talking about my first trip to Washington, D.C. as an 8-year-old.
Yeah.
I was in status asthmaticus. And for the non-medically inclined out there, that's literally when your asthma gets so severe that you cannot breathe. And I had to be medevaced from a small rural community where I grew up in to Children's Hospital in Washington, D.C., and not knowing if I was ever going to see my parents again because my parents couldn't fit in the helicopter. They shoved me in a helicopter. They fly me to DC. I remember my parents saying, "We'll see you in a couple of hours." And they hop on the road and race up to Washington, DC to try to meet me. But I tell that story because it's really what has inspired me to continue to advocate for public health. And what I mean is, I can't tell you how many times in my career I've been the only, and I'm doing my air quotes here, the only at the table, the only African American, the only person who grew up below the poverty line, the only person who understands that when you're talking about virtual school, that's a very different concept if you live in the suburbs than it is if you live in a rural community where they don't have good broadband access. And so a lot of my reasoning for going into public health and in public service is to be a voice for people like the 8-year-old me who didn't have all the resources to be able to make good health decisions. And that's another point that I really try to drive home to folks is that, yes, health is a lot about your individual choices, but the choices that you make are 100% dependent on the choices that you have in front of you. And if you don't have a grocery store, a Whole Foods right next to, right down the street from you, if you don't have the ability to go out and pay $10 for a bag of apples at Whole Foods, then you're not going to be able to eat healthy, even if you want to. And health equity, which is my role at Purdue University now, I'm the director of health equity, is really about making sure people have the opportunities to make healthy choices.
Mm-hmm. Mm-hmm. And transitioning from your education as not just a clinician but as a public health expert, you in 2014 you are appointed, as I mentioned in the bio, as Indiana State Health Commissioner, and here you are given literally, the broad swath of responsibilities, everything from tobacco prevention and cessation, health protection and lab services, regulatory issues. And I found it very interesting. I took a look at, a lot about what you were publishing on at the time. And I saw this really almost an interesting little microcosm of what we'll later get into when you become Surgeon General. You publish on topics like breastfeeding and infant mortality, some quick wins there, right? That not a lot of people object to that. On the other end, there's obviously the New England Journal issue with the HIV and the needle exchange programs. Obviously, causes a little back and forth there in the health literature, and then sort of in the middle, you're publishing about the opioid epidemic, which at the time, it wasn't a social determinants article. It was more about a prescribing determinants, talking about sort of the issues of pain management questionnaires, and are we missing something there that people are transitioning to these other nasty drugs after the opiates and so forth. Talk a little bit about that time, because I think it's very important, because I think everything you were involved in then, the easy and the very hard, translate to why you ultimately, made a great Surgeon General.
Well, I really appreciate you bringing that up, because I was only the second Surgeon General in history to have previously run a state Department of Health.
Yeah.
And that is important for a number of reasons. First of all, people don't realize that constitutionally, most of the health authority in our country lies at the state level
Yeah.
and not at the federal level. So when I'm Surgeon General, everyone is saying, well, why don't you just make everybody wear a mask? Why don't you just enforce this vaccine mandate? Why don't you just do X, Y, or Z? The reality is I had more power and authority when I was the state health commissioner of Indiana than what I did when I was the Surgeon General of the United States.
Yep.
And if you haven't been in those roles, you don't understand that that is where most of the ability to impact public health sits. And it's why when I was Surgeon General, one of the most successful things that I did, and no one talks about this because they don't understand it or know it, was that I had very good relationships with the states, with the governors, and with their health officials. And that is how you have to actually get people to adopt policy measures. You can't, and we saw this under the Biden administration. They tried, Biden swore he was going to give us a mask mandate if he became president of the United States. We're now up for his reelection, and we've never had a federal mask mandate. Why? Because the authority lies at the state level.
Yeah.
He tried a vaccine mandate, and the Supreme Court declared it illegal. Why? Because the authority lies at the state level. And so I think that's an important point for people to understand. I mentioned Brian Castrucci in my book. He has famously said, your governor has more control over your health than what your doctor does.
Yeah.
And when you think about issues like women's health, abortion, guns, syringe service programs, in many cases, it is those state level policies that have more of an impact than even your own doctor in terms of the choices you have in front of you. And so I feel honored to have been able to serve as state health commissioner. And what concerns me now is how public health officials are under attack.
Yeah.
And I don't mean this even tongue in cheek. I mean this very literally. They're receiving death threats. They're being attacked on social media, and you're pushing good people away from being willing to take on these incredibly important jobs that, as you mentioned, I dealt with lead contamination in the community when I was health commissioner. I dealt with HIV and STD outbreaks, and we've got record numbers of congenital syphilis cases now going on in this country because we haven't been doing enough to combat sexually transmitted diseases. So many different things that public health does for you that are going to fall flat if we don't have good people serving in those roles.
Mm-hmm.
And I think it really set me up well to have the relationships that I needed as Surgeon General. And I talk about this in the book too. One of my favorite sayings is people need to know that you care before they care what you know.
Right.
And that is whether you're talking about an individual, a patient, or whether you're talking about other health officials and government officials at the state level. And so I had those relationships coming into my role as Surgeon General with people all across the country that really helped me. But the final point I'd make about that is that the Surgeon General role it has to be a physician legally, and that makes sense to people. But in many cases, physicians without public health backgrounds don't understand all that public health does for you. They look at it through the medical model. And what do I mean when I say the medical model? Let's take diabetes, for instance. You have a person who has diabetes, and you prescribe them insulin, you take their blood sugar and follow the hemoglobin A1C, and you can do that perfectly, but you're still not going to control their diabetes if you don't understand that they live in a community where they don't have access to healthy foods.
Right.
And all they're eating is carbohydrates that they can get from the local from the local convenience store. You're still not going to be able to control their diabetes if you don't understand that they live in a community that doesn't have complete streets, that doesn't have sidewalks, so they can't go out and exercise. They don't have parks and green spaces where they can go outside. And so a public health mindset in many cases is very different than a traditional medical mindset. And I'm blessed to have had that experience both in the medical world, working in a hospital, which I still do, and seeing the end results of uncontrolled diabetes, but also working in a health department where I could help prevent people from getting diabetes in the first place.
Mm-hmm. Mm-hmm. Continuing along that, and before we get into some of the other programs, sort of pre-COVID and during COVID that you were responsible for as your time as Surgeon General. Can you say a few words about the United States Public Health Service Commission Corps? Because, it's one of, and you point this out, I say in the book, yeah, I'm not a surgeon, I'm not a general. Um, and, when you go to the HHS website and you go through the organizational chart where everything's happening, the USPHS is sort of over on the side. I mean, yeah, I had to click I got to click a button, and it took me elsewhere, right? It takes you to their specific website, and it talks about the 6,000 uniformed officers and all that. It's not listed in the hierarchy of everything else. Why is that? Can you say a couple words about it?
Well, absolutely. So the U.S. Public Health Service is actually one of the 8 uniformed services. There's Army, Navy, Air Force, Marines, which most people know about. There's Coast
Mm-hmm.
Guard. There's National Oceanic and Atmospheric Administration.
Yep.
There's a newly formed Space Force now.
Yep.
And then there's the Public Health Service. The Public Health Service is actually older than the Air Force. It's one of the oldest uniformed services. Why? Because going back all the way to the origins of our nation, we understood that if you did not control diseases, particularly infectious diseases, from coming into your country, that it was a national security threat.
Mm-hmm.
And it's so interesting that here we are again with COVID, having these debates that originated back in the beginning of our country, when folks said we can't let smallpox, we can't let measles, we can't let plague into our nation. We have to have people who are monitoring this and who are helping us control outbreaks. So that's how the Public Health Service started, interestingly enough. And I'm an admiral, or I was an admiral, because they would stop ships of immigrants as they came into the country, and we'd go out with the Navy, and we go out alongside them and inspect the ships before we would let them land, to make sure, again, we weren't importing disease into our country. Over the years, as you mentioned earlier on, the position continued to grow and evolve to include things like smoking, chronic diseases like diabetes, and high blood pressure. And I'll be honest, it also got more and more controversial as people took on a more comprehensive view of health. Why? Because then you start to talk about issues like guns.
Yep.
You start to talk about issues like drug use. You start to talk about issues like women's health. And these are all issues that are more and more politically controversial. And over the years, as the Surgeon General and the Public Health Service took on more of these issues, you saw them get more and more sidelined by the political powers that be, push further to the side, push further down the hierarchy. The Surgeon General actually used to run the Department of Health and Human Services, used to essentially be the HHS director. Now you're 3-4 levels down. That is not by coincidence. That's in many cases because of the politicization of health issues. But they still, and we saw during the pandemic, are an incredibly valuable resource for this country. They're the only uniformed health service in the world. And not only are our folks helping in the United States, we sent people over to China. We sent people over to help repatriate Americans during COVID who were stuck overseas. We're helping control disease in Africa when Ebola outbreaks. And we've now seen that if you can't control those diseases outside of the United States, they're only a plane ride away from your front doorstep. And so an incredibly important service that we need to continue to fund. Unfortunately, public health suffers from a PR problem. That PR problem, like I said, you don't ask yourself, is my water safe to drink? You just assume that it is. And if something goes bad, then you want people literally to be put in jail because they didn't do their job. Public health is invisible when it goes well. It becomes very visible when it goes poorly. And not just the Trump administration, but going back to the Obama administration, both of them tried to cut the public health service. And I talk in the book about how I spent a lot of my tenure early on fighting to save the Public Health Service Commission Corps from being completely wiped out.
Mm.
because people said, why do we need these folks? Lo and behold, a few years later, we have a once in a century pandemic, and it's not why do we need these folks? It's, hey, why don't we have more of these folks to send out and help respond to the pandemic? Why aren't you doing more?
Yep.
And that's the problem, again, that public health has, that again, folks don't appreciate it when it's going well.
Yep. Absolutely. Yeah, and I appreciate you breaking down the history of that for us, because I think it puts everything else into in perspective where we'll go next. But
And if any
yeah,
listeners are interested, I encourage them to look up the public health service. It's not just about doctors.
right.
We have 11 different categories: doctors, nurses, vets, dentists, engineers. Interestingly enough, we have a lot of engineers who work again to create the infrastructure that helps keep like water treatment plants,
Hmm.
septic systems that help keep our communities safe. All of that is public health, and we need good people. And if you're ever interested in serving your country, please look up the public health service. It's the proudest moment of my life to be able to wear that uniform and to be able to feel like I'm serving my country. I don't want to go off the rails here, but I do look at a lot of other countries and I ask myself, what's different about their country versus ours? I'm a big fan of mandatory public service.
Mm.
In a lot of countries, Switzerland, for instance, Israel, for instance, has compulsory military service.
Right.
I don't know that I'd be in favor of that, but I do believe that if everyone was compelled to serve in some way, shape, or form, that it helps create feelings of camaraderie, of patriotism, and it really, I think, gives people a sense of pride in themselves. And I really would encourage folks to try to find a way to serve your country, your state, your nation for your good and the good of your communities.
Mhm. Definitely. One of the areas, as I mentioned, I look at your time as Surgeon General sort of divided between sort of pre-COVID and COVID, and I'd like to just stop at two places before we get into the COVID era, because I think stuff you were working on earlier on, again, there's themes here that are extremely important. One being, well, actually, you published a couple articles in what was known as Public Health Reports in 2018. One that had to do with Hurricane Maria and a generation of restentia, which you define as sort of resilience, this ability to bounce back from these challenges that occur. Clearly, major hurricanes coming together, it was an example of that, and ultimately how you rebuild after that. And then the other one was your article, "The Value of Wellness." Here again, where you're tying in this theme of how in public health, the employer becomes an important part of the community health equation. And I'd like you to just to say a couple words about both of these, because clearly they both prove important themes as you dealt with COVID. So if you could say a few words about both of these articles, I think that'd be important.
Well, number one, I think it's important for us to understand that the greatest advances in health policy on our planet have often come on the heels of tragedies.
Yeah.
So when you look at World War One, that's when we saw massive innovation in blood transfusion therapy.
Yep.
Why? Because people were dying and we needed to respond. Tens of millions of lives, hundreds of millions of lives have been saved because of the tragedy of World War One. A lot of people don't understand that the first Operation Warp Speed was actually during World War II. It wasn't to produce vaccines; it was to produce penicillin, because people were getting infected from these war wounds that they were now living with because of the innovations in transfusion therapy from World War One. And so we saw massive innovations during COVID. We saw Operation Warp Speed obviously has changed the way we're going to make drugs and innovate forever. But we also saw an 8,000% increase in telehealth services. So the way that we actually get care changes. And so when you think about hurricanes, there is a resilience that these tragedies actually bring out of societies.
Yeah.
We're at each other's throats, but we galvanize around a common enemy. And what's interesting with COVID is we actually did come together for about 4 to 6 weeks in February, March. People were making masks. companies were repurposing. There were alcohol companies that were making hand sanitizer.
Yeah.
It really did bring out that sense of camaraderie for about 4 to 6 weeks. Then what happened? Well, what happened was the election. We had a pandemic superimposed on top of a presidential election, and the presidential primary started. And so people started to see that their positions on COVID could help them distinguish themselves from the candidate they were running against. And all of a sudden, everything became politicized. And we lost the ability to communicate about this in a nuanced sense. It was either you're 100% for mask and that makes you a Democrat, or you're 100% against mask and that makes you a Republican. You're 100% for shutdowns and that makes you a Biden supporter. You're 100% against shutdowns and call COVID a hoax and that makes you a Trump supporter. And so I really think it's important that we reflect on how tragedy can help us galvanize around a common enemy, and how COVID plus the election disrupted what has normally occurred after tragedies in 2020. I think it would have played out very differently, COVID would have, if it hadn't occurred during an election year. So and that's a major point I bring up in my book that we can touch on again perhaps later. But politics plus the pandemic made this a toxic brew unlike anything that we've ever seen before, notwithstanding the fact that it was a once in a century pandemic. But the other point that you brought up, I think, was also highlighted during the pandemic. It's something that I was trying to promote even before COVID, and that's the connection between business and health.
Yep.
So the number 2 expense for most U.S. employers is healthcare. When you buy a General Motors car, you are paying more for employee healthcare than what you're paying for the steel that goes into that car. And we're getting to the point where we are no longer able to be globally competitive as a nation because of our poor health and because of our healthcare cost in this country. So the point I make in a report that I actually wrote when I was Surgeon General, first of its kind report, because it wasn't written for a health audience, it was written for a business audience, is that we need to invest in healthier communities. We need to create opportunities where people can have better baseline health. And we need to do it not because of the individual. A lot of the debate about health care access and health in this country really still gets boiled down to individual responsibility or personal responsibility versus government responsibility. And you see the people follow along those political lines. Should everyone have health care? Well, we believe that health care is a right. Well, we believe that you should work and you should earn your own health care. And that's how candidates look at it. Well, I look at it very differently. In my mind, health is a national security issue and it is a business imperative. Because how many people who are listening right now have gone to a restaurant in the last month and gotten poor service because they didn't have enough people working in the restaurant?
Yeah.
How many people have tried to go to a store and the store closed early because of lack of employees, or it wasn't open? We're starting to see the real impacts of poor health on the workforce, and in turn, our ability to be economically vibrant as a society. And so, again, I really call on employers to understand that they have a role to play in creating the conditions for a healthier society, because it's going to create a healthier bottom line.
Mm-hmm. Absolutely. Yeah, and I like the piece where where you're talking about the sort of the place at the table when COVID did strike, and you were talking about, hey, the Secretary of Commerce is sitting next to me here, and okay, now again, from a perspective of we're shutting down this economy, we're doing this and that, and having it's one of these important learnings that you talk about, and having a place at the table, and even if you don't get to say something during a certain meeting, it's important to be at that table and understand all perspectives and things that are going on.
Can we dig into that a little bit?
Sure.
Because that is an important point I make in the book. Is I got attacked by health officials because they felt like I should have been screaming and yelling, or health advocates screaming and yelling every chance I got about how we needed to make health the number 1 priority. And a point I make in my book is, in the Situation Room, it was me sitting there next to Homeland Security. And yes, health should be your number 1 priority, but your immigration policy impacts health. Are we allowing people in and out of the country who are transmitting diseases? Your economic policy impacts health. And in turn, health impacts your economic policy. So shutdowns, yes, they helped us slow the spread of COVID somewhat, but they also hurt people who didn't have salary jobs, who were a part of the gig economy. And those folks are saying, hey, if I can't drive my Uber, if I can't go out and earn my income, then I don't care whether I get COVID or not. I can't put food on the table. Housing, we had the HUD, Housing and Urban Development, at the table. Why? Because we needed to put in place rent protections for people who couldn't pay the rent because they couldn't work. So again, your health policy impacts your ability to have a place to actually live. Education. I make the point that we honestly did not think enough about the impact on education early on during the pandemic. We were focused on health. And in turn, we weren't thinking about the fact that, hey, when kids are out of school for a prolonged period of time, that can actually have negative impacts on their mental health and their ability to be physically healthy moving forward. Fascinating statistic. We actually saw reports of child abuse go down during 2020. And you might think that's a good thing, but it's not that kids were being abused less. It's that a lot of the child abuse gets reported when kid comes to school with a black eye, and kids weren't going to school. And so that was something that no one thought about. But in future discussions like this, I think we need to make sure we have education at the table from the beginning. And so the point I'm making here is, yes, health is a critical variable in our policy discussions, but it is not the only variable, because people can be harmed by more than just COVID, even in the midst of a once-in-a-century pandemic.
Mm-hmm. And going a little bit further with that one, because obviously, the table that you were talking about in the book is obviously the team that was put together, at the White House, and with Dr. Fauci and Dr. Collins and everybody else, all the big wigs, talking about this issue as it was unfolding. But clearly, in this world of social media and where we are in 2024, the table, it sort of constitutes everybody nowadays, right? And there was an important quote, I thought, in the book, if I could read it here. You said, when people feel that they aren't allowed to talk about disparities in health and healthcare, or that their personal perception of risk isn't being respected, they often stop participating in important conversations and grow increasingly more frustrated and divided. And I think that is basically encompasses a lot of where we've gotten. And I was wondering if you could say a few words about this, and how we deal with a little of this. And then we'll talk a little bit about misinformation later on.
Well, I mentioned that most of the authority lies at the state level in terms of health. And that's a good thing. That is a good thing. So I want to tell you about one of the challenges we had during the pandemic. Tony Fauci and I were both still working in the hospital. We were getting direct communications from physicians. And in February, March of 2020, our colleagues are calling us from New York saying, we're imploding. We are literally to the point where we can't safely care for patients anymore. And this was on the heels of, again, Wuhan imploding, Italy. Their health system completely fell apart. There were people who weren't even being allowed into the hospital. They were dying, out in waiting rooms. And we didn't want that to happen in our country. And so we're getting these calls from New York saying we're right on the verge of this. And so we told the country we need to shut down. Because we need to prevent this from happening. We need to slow the spread of disease while we catch up and figure out what the heck is going on and react. Well, the problem with that is that while New York was imploding, Boise, Idaho was not experiencing nearly the same level of impact. They were saying, oh my gosh, I don't know a single person who's died from COVID. Why are you making my business shut down and hurting my livelihood? Why are you making my kids stay home from school? And a lesson from the book is that in the future, we need to be in a position to have more nuanced advice and not nationwide shutdowns, not nationwide advice, because the United States is a big place. Geographically, things aren't going to happen all across the United States. You know, we don't, when there's a hurricane happening in Florida, we don't say, okay, well, we need to shut down in Idaho or in Montana. But that's what we did with COVID. And I want to own that, but I also want to say one of the challenges was that we didn't have public health infrastructure to be able to tell us that what was happening in Montana was different than what was happening in Michigan or Mississippi. So we need to make sure we're funding the CDC and state health departments so that we can get prompt testing, so that we understand what's going on, so that we really can make informed decisions, because poor data makes for poor decisions. And we saw that happen during the pandemic. Tony and I and others made the best decisions that we could, given the information and the data we had at the time. But in hindsight, we need to be honest that those decisions in hindsight were not appropriate for the entire nation. And in order to do better in the future, it's not to say get rid of the CDC. It's not to say put Tony Fauci in jail. It's to say, how do we make sure whoever that person is next time has the information and the data to be able to make a better decision the next go round.
Mm-hmm. And you talk about at that time the 40-70 rule, which I believe Colin Powell taught you. I thought it was a very good rule, and you can say a couple words about it. Except one thing popped into my mind. I made the decision about my wife long before I knew 40% about her. I knew she was the one. But anyway, say a couple words about the 40-70 rule.
Well, you know, the 40-70 rule probably applies to marriage too, because my wife and I celebrated our 20th anniversary this year, and I hope you and your wife are together for quite a while, but divorce rates are at an all-time high. I think people are jumping in before they have 40% of the information. So the book, I talk about a number of well, for lack of a better word, famous people who I had the opportunity to interact with. And it truly was a blessing. Everyone from Colin Powell to Chef Jose Andres to Oprah Winfrey to Axl Rose, just an amazing assortment of individuals that I had the chance to interact with, some positively, some negatively, during the pandemic. And in my role as a Surgeon General. But Colin Powell, I really value his advice. You know, 4-star general, been through some very tumultuous times as a leader in our country. And he has this 40-70 rule. He said that if you make decisions before you have 40% of the information, you're likely to be wrong. He said, but if you wait until you have more than 70% of the information, you're likely to be irrelevant. You're likely to be too late in terms of making a critical decision, an impactful decision. And interestingly enough, we saw the CDC was wrong on both sides of the 40-70 rule over and over again during the pandemic. Oftentimes, we were forced to make decisions before we had 40% of the information. And those decisions, in a lot of situations, were not the best decisions that could be, because we didn't have the information that we needed to make an informed decision, again, about school closures, about shutdowns, et cetera. However, the CDC also often waited too long to make policy decisions. They waited well beyond having 70% of the information because they wanted to have 110% of the information, and they were irrelevant. States had decided that they were going to go back to school long before the CDC put out guidelines on how to safely go back to school, and people stopped listening to them. With vaccines and boosters, in many cases, the CDC wasn't putting out information in a timely manner so that people could make good decisions about whether or not they should get those updated shots. And again, to bring it back to the husband and wife or your spouse situation, you're going to make a wrong decision if you don't have 40% or more of the information a lot of the time. But if you wait until you have more than 70% of the information, someone else is going to snatch your partner up. And so the 40-70 rule works in relationships as well as in pandemics.
Awesome. You talk about Well, it's two intersecting themes here. Obviously, the importance of improving the science and health literacy of the country, and at the same time, getting rid of all this mis and disinformation out there. I know that you were a couple months ago. You and I think five other former United States Surgeon Generals got together at Dartmouth to talk about these issues at a roundtable. Could you say a couple words about both of these and a little bit about what was discussed at that time? And do we have, I know this is a tough one in terms of
No, no, no,
coming up
no.
with
It's it's
solutions,
it's
but
it's something that I really do enjoy talking about. I wish I didn't have to, but I think it's important to talk about misinformation and disinformation. Um, we are in a world now with social media, with chat bots, with outside actors. A lot of the information we're consuming on social media is actually nefarious information coming from anonymous accounts that are based out of China and Russia, trying to sow dissent within our country. And so it's important that people understand that there are people out there either making money or trying to gain a political or national security advantage against our nation by sowing misinformation and disinformation into the general populace. Misinformation, and I explain this in the book, is just simply wrong information. Disinformation is people who are doing it purposefully trying to mislead you. And it's a public health crisis right now, because there are people who are literally choosing to hurt themselves. I'll give you an example. Paxlovid is a medication that folks can take if you are diagnosed with COVID that significantly lowers your chances of being hospitalized or dying. It is incredibly underutilized. Why? Because of misinformation and disinformation that has dissuaded people from being willing to take it. I'm not even talking about vaccines here. Vaccines, obviously, but Paxlovid. There's not a lot of debate when you talk to people in general about, hey, if I get COVID and I get sick, would I like a medication that would help me get better quicker, and stay out of the hospital? But the misinformation and disinformation are costing lives. So we talk a lot about how to combat that, and health literacy is a big part of this. We need to look at elementary schools, middle school science classes. Right now, there is a debate. There is a certain health official in a certain big state who has come out and spread misinformation about the vaccines. He has said that that you can have your DNA changed from the mRNA vaccines. I want your folks to, and one of the challenges with misinformation and disinformation is when you try to combat it, you actually raise it up. So we're talking about this on your podcast, and there's the real danger that we're actually spreading this misinformation. But I want people to understand how this plays out.
mm,
This is related to people's lack of knowledge about basic science. The mRNA vaccines do not enter the nucleus of your cell. The nucleus of your cell is where your DNA resides. Therefore, you cannot change your DNA with an mRNA vaccine. But yet we have a health official, a physician, who is telling people that something can happen when basic science tells us it can't. And so if the general public knew more about basic cell biology, they would understand that this literally is not something that can happen. And that's an example of both people out there who are trying to gain an advantage in other aspects of life, have other agendas, saying things that aren't scientifically plausible,
yeah,
and a populace that doesn't understand basic science, lapping it up, being led astray by that misinformation and disinformation. And so we both need to lift up the knowledge base of the general public, and also help people better be able to identify bad actors and call out those bad actors.
absolutely, absolutely. I wish we could teach the public a little bit more about pharmacokinetics and pharmacodynamics when it comes to some of the themes that you were just talking about, but we'll get into that on another show. But that being said, I mentioned in the bio of the show, of course, that in addition to your many responsibilities now, you are a professor in the departments of both pharmacy practice and public health at Purdue, and I'm a pharmacist by undergraduate training. So is my father. My father was from that era of, his his customers called him Doc. They didn't call me Doc. I don't have a PharmD, but I went through that transition of where pharmacy became more than pharmacy, more into disease management. You look at pharmacy nowadays, you can spend a lot of time in your pharmacy and you can get your pills, you get your vaccines, high blood pressure tests, and all that. Say a couple words about, because we hear about sort of access. And pharmacy is one of those areas that, I can go to my pharmacy multiple times a day, every day. Well, I might see my primary care physician only once or twice a year. Talk a little bit about what you're teaching about in terms of a pharmacy and sort of pharmacy's role as a steward in this public health equation.
Well, I'll jump into that, but I want to hit on something that you brought up really quickly. You brought up how they called your dad Doc.
Yeah.
And I think that's one of the challenges we also have with misinformation and disinformation, is that once upon a time, your pharmacist, your physician, they were looked at as the authority on health issues.
Yeah.
They were looked at with a reverence, and with a respect for that was well deserved, as someone who, when they're giving you health advice, that's health advice you can trust. Now people go to Dr. Google. They don't go to to your dad. They don't go to Dr. Pastor. They go to Dr. Google. They're going online, and we've lifted up all of these, in many cases, anonymous or nefarious actors to the same level as someone who actually has a degree in pharmacology, or a degree in medicine, or a degree in nursing. And I think we again need to figure out how to get to a place where, yes, we're giving everyone the opportunity to participate in a conversation, because I like the democratization that social media has brought about, but where we also still respect the fact that, hey, this person went to school for this, and so yes, they do deserve a little bit more of your attention when they're speaking on this issue than some random person who's tweeting out from their mother's basement on social media, or a Russian bot who's simply sowing misinformation out there. But I think you brought up another point, which I think is incredibly important, and that is how the pandemic has accelerated a change in the way we look at pharmacies and pharmacists. A lot of this was happening prior to the pandemic in small ways. When I was health commissioner of Indiana, I helped change the laws in our state to allow pharmacists to be able to administer childhood vaccines. It was actually incredibly controversial at the time that we did it. But that said, it really set us up well when the pandemic hit to be able to actually make it easier for people to access care. So again, it's amazing our memories. People, well, it's easy for them to forget that prior to 2020, it was an odd thing to think, okay, I'm going to go to the pharmacist to get my vaccination. I'm going to go to the pharmacist to get tested for a disease. I'm going to go to the pharmacist or to the pharmacy to get treated for a disease. Well, now that's completely commonplace. You go to the pharmacist to get your COVID vaccines. Most people will go to their pharmacist before they go to their doctor to get their COVID vaccines if they're going to get an updated COVID vaccine or flu vaccine. Mm-hmm. You can go there and get tested for COVID or flu. You can go there and get treated for COVID or flu. And you mentioned something that I don't want us to gloss over. Most people in the United States go to their doctor once a year, if that. If you're really sick and you have multiple chronic diseases, you go more frequently. But most people, we struggle to get them to go in for their annual checkup. So they may not see their doctor, even once a year. But most people will go into their pharmacy, multiple times a year, oftentimes once a month or more for something. And so the more we can use pharmacies and empower pharmacists to actually deliver health resources and health advice, I think the better it will be for our society overall. And so I'm a big advocate for leveraging pharmacists. I believe the stat is no one in the or most of the United States live within 5 to 10 minutes of a pharmacy. And again, I think about going to my own doctor. I've been to my pharmacy 3 times in the last month. My pharmacy is literally 5 minutes away from my house. My doctor's office, I literally only go there if I have a problem. And my doctor's office is I'm still fortunate, but it's 20 minutes away. When I grew up in rural Southern Maryland, my doctor's office was about 45 minutes away. And so important that we continue to leverage all providers to be able to increase access to care, because we don't have enough doctors. We don't have enough nurses. And even if we did, the places where those doctors and nurses tend to be is often not convenient for folks to be able to access, particularly if you're from a under-resourced community, you're working multiple jobs, you don't have childcare, you don't have time to drive to the big hospital complex or medical complex, in the middle of the day when they're open.
Absolutely. Dr. Ives, I want to now take a trip back a couple of years, because it's one of the theme I want to touch on. Because obviously I mentioned you've been involved at various points in your career in dealing with the opioid epidemic. Back in February of 2016, you gave testimony before the United States Senate Select Committee on Aging, and the topic of the hearing was opioid use among seniors, issues and emerging trends. And this one sort of hit home because my mother, and just a short anecdote here, she didn't have an opioid issue, but she had a benzodiazepine issue. Started in the 1960s, where these things were also handed out sort of as a nice little candy that help you sleep and relax you and all that. And she developed a major addiction over her later life, and it was one of those things. Her doctor was like, all right, honey, just take it for the rest of your life type thing, and don't worry about it. And it comes back to this thing of, sort of, on one hand, sort of ageism, this ism that no one wants to talk about. But this important, the seniors in our country make up 120 million plus folks that, put aside all the chronic degenerative diseases, this is something that we don't even think about at all as we are in the middle of this opioid epidemic, that we have, these elders, this very respectful, this population we should be extremely respectful of, that we're not paying as much attention to. Talk a little bit about, if you could go back to 2016, talk a little bit about this testimony and the subcommittee. And then if you could say a few words just from the perspective of public health and aging and some of the sort of the issues that you think we should be focusing on more in 2024 per that topic in general.
Well, before the pandemic, the COVID pandemic, the epidemic and pandemic we were dealing with was of opioid misuse. And a lot of that was driven, as you've mentioned several times during our conversation, initially by overprescribing.
Yeah.
Overprescribing of benzodiazepines and of Vicodin, of oxycodone, and we talk about these things even though benzodiazepines and opioids are different classes, because they can synergistically work to decrease your respiratory rate and contribute to your risk of overdose. Yeah. And so when the opioid epidemic was primarily being driven by prescription drugs, we were seeing overdoses in seniors. Again, as you mentioned, because there were folks who were coming in who've been on benzodiazepines for years. And then they tweak their knee, or they have hip surgery, or they have a knee replacement, and then they get put on oxycodone, for recovery. And unfortunately, in many cases, many people leave the hospital on what is supposed to be temporary opioids, and they're on them a year or more later still, because they're not properly weaned off. But that said, then you have the opioids combining with the benzodiazepines, creating this situation where you're seeing overdoses. So I was talking about the need to prevent this from happening in the first place by being more judicious with our prescribing. I was talking about the need to make sure we're giving seniors alternatives, because what you don't want to do is pull the rug out from underneath of them.
No.
You don't want to say, hey, we're not going to treat your knee pain. But there are other modalities that are out there and that we need to continue to develop, which in many cases work better than opioids for treating pain. Opioids in many cases just mask your pain. They make you sleepy. They don't actually treat your pain. We need to make sure we're identifying people who are on too much opioids, dangerous amounts, and appropriately wean them down. So we need pain management specialists and addiction specialists who can help them get to a safer dose, or ideally no dose of opioids at all. And we need to create communities where we remove the stigma from even talking about this issue. We're getting there, but I still recognize there's a lot of stigma against acknowledging that, hey, I've got a problem. I'm dependent on these things. I need help. Or people being willing to take a loved one in and acknowledge that their loved one has a problem with addiction. So that's a lot of what I talked about, and what I continue to emphasize is prevention, treatment, and then creating stigma-free communities when it comes to opioids. But seniors in general, there's a business imperative, there's a societal imperative beyond the moral imperative of doing right by our seniors. They're getting to the point where if we don't, then we are not going to be able to continue to be. Look at Social Security, look at Medicare. If we can't keep our seniors healthy and functional longer, they're going to continue to drain our societal resources. Medicare and Social Security worked for most of our lives because the pyramid was in such a way that there were more people paying in than pulling out. Well, that's been reversed now. Now you've got so many folks who are over the age of 65 pulling out of the system, and fewer people paying into the system, that economically it doesn't work. And the only way we can make it work is to make sure we're supporting the health of our seniors so that they can be functional longer and they're not costing us due to their poor health, but also that we can create societies and communities where they feel like they can and want to work longer, and they can help contribute to the workforce.
Yep. And this is an extremely important theme that we touch on a lot on the show, this concept of health span, and ultimately how we can extend that period of healthy life before we get to the period that really costs society quite a bit. And so now I
and it
appreciate
also is a mental health issue, believe it or not. Folks don't appreciate this. In the United States, especially, for better or for worse, and I've lived in Europe, I've lived in Holland. In Holland, they say that they work to live, meaning that they do as much work as they have to so that they can actually live and enjoy the rest of their life. In the United States, the saying is that we live to work. When we introduce ourselves, the first question we ask is, what do you do? We define our day and our week, and we identify ourselves through work. And I say that because, again, for better or for worse, that's who we are. And when people hit 65 and they retire, and they're living now to be 85 plus years old, that's a long time to not have an identity. And you see mental health suffer. You see people retire and they're happy for a few weeks, and then all of a sudden they're lonely, they're depressed because they no longer have an identity. And we need to figure out ways we can keep those individuals healthy, but also find ways to keep them integrated into and involved in society. Maybe you do retire from your job you've been at for 30 years, but you go out and you become a coach, or you find a second career where you can continue to participate and be part of society. I think we need to do that, so that, again, we can improve the quality of life and not just the quantity of life.
Mm-hmm. Absolutely. Dr. Hans, while we have you, can you say a few words? I know you lead the health equity summits that occur at Purdue. I think you have one coming up at the end of February this year. Can you talk a little bit about the health equity summits, and then a little bit of what's going to be going on? Any highlights about what's going to be happening February this year?
Oh, wonderful, wonderful. So I love talking about that. Again, health equity is really just about making sure people have opportunities to make healthy choices. I'm in Indiana right now. We have a large rural population here in Indiana. And so health equity is everything from making sure we have access to broadband to making sure folks in rural communities can have access to doctors and nurses and pharmacists and psychiatrists, to making sure people who are differently abled can access care and services, to making sure we're addressing the fact that Black women are 3 times as likely to die while giving childbirth as white women. It's just digging into the different causes of disparities, but also making sure everyone has an opportunity to make a healthy choice. And at Purdue, again, we have a focus largely on rural communities, but also on how we can use biotech. A lot of people are familiar with Purdue because Neil Armstrong went here. We produced more astronauts than any other public university in the country. We're known as Astronaut U. We have a very strong engineering and biotech background.
Yep.
And when you look at AI, when you look at medical devices, who better than Purdue to actually increase access to care and quality of care through leveraging biomedical innovation. And so that's a lot of what we're focused on here at Purdue. And we have a summit coming up where we're going to be featuring as our keynote speaker, Dr. Francis Collins, who is the scientific advisor to President Biden and the former NIH director. And a lot of what we're going to be talking about is how academic institutions can be better community partners. What's interesting is academic institutions have so much potential, but there's often a disconnect between the very, I would say, esoteric and theoretical research being done on college campuses and the real needs that are happening at a community level. And we want to figure out, how we can better leverage those faculty and students and expertise, but also that innovation to drive real change at the ground level, which is fits right in with Purdue's land grant mission. Land grant institutions are institutions that are literally and legislatively supposed to be producing outputs, both research and graduates that are driving change at the community level. And so Francis Collins and I are going to talk a lot about that, and we're going to try to continue to improve upon Purdue's commitment to its land grant mission.
Awesome. Well, that's an awesome, outstanding keynote, and the one other area that I remember from a couple episodes I did last year is that Purdue has this really interesting advanced program in so-called human factors, and sort of as you were mentioning biotech. There's this sort of tech bio thing, whether it's human machine pairing or age tech, or all the potential applications. You were just talking about AI and how humans are going to ultimately team with these devices as we move forward for health and various other purposes. And then that's exciting. Any final messages while we have you? I mean, I could go on for a couple more hours with you, but anything I missed, any other upcoming initiatives, presentations, appearances where we could listen to you, run into you possibly, anything else, please take the floor.
Well, what I would just say to folks is I really hope they will get a chance to check out my book, Crisis and Chaos. Available on Amazon, Barnes & Noble, wherever books are sold. I'm not writing the book to make a profit. I actually donate the profits back to purchase more books that I can give away to students. Why? Because I grew up not believing I could be a doctor, because I didn't have any role models around me who done that. And I want students to understand my journey of becoming Surgeon General of the United States, so that hopefully it will inspire them to be public servants. And I think that's important. We need good public servants, number one. Number two, in the book, I really help people. I don't shy away, and you've read it, from acknowledging mistakes, but I try to help people understand here's why the mistakes occurred.
Right.
And here's how we can do better in the future. We can't prevent it from happening in the future simply by pointing fingers. We have to say, what were the foundational issues that caused us to make those mistakes? And one of those foundational issues was a poor public health infrastructure. We need to strengthen our public health infrastructure, not defund public health, if we want to prevent these problems from happening in the future, because we're going to continue to make bad decisions if we don't have good data and good infrastructure. And the final point that I make in the book is we have to recognize our own biases, particularly our political biases, and how they shape the way that we engage in conversations and the way we absorb information. I want to finish here on what is going to at first sound like a negative or a political swipe, but it's not. It's a fact that I think we need to acknowledge. Joe Biden, October 2020, said in the final presidential debate that he had against Donald Trump, that any president responsible for 200,000 COVID deaths should resign, should no longer serve as president. He made it the defining and closing argument for his campaign. And he was elected president. Well, fast forward to the end of 2021, 360,000 people died under the first year of the Biden administration. This was despite now having vaccines, despite having home tests, despite having treatments like Paxlovid, despite having ample supplies of PPE throughout 2021. We had none of that in 2020. You go even a year beyond that. So let's say you give them a honeymoon period. In 2022, 240,000 deaths. So still more than what Joe Biden said should disqualify you from being president of the United States. Now, this isn't a swipe at Joe Biden. This is to say that the premise that changing who was at 1600 Pennsylvania Avenue and changing the CDC director and changing the Surgeon General and changing the FDA commissioner was going to drastically change our trajectory, that premise was proven wrong. Whether you like Joe Biden or whether you like Donald Trump or whether you like somebody else, that premise is wrong, and the numbers tell us that it was wrong. So my book is really about helping people understand what beyond changing the captain of the Titanic is going to prevent us from hitting that iceberg in the future. And so I hope people will read the book. I guarantee you'll be surprised because, again, I pull no punches against myself or against anyone else. And I call out the problems with our administration. I call out the problems with the current administration. But I really try to bring it back to, and here's the lesson we need to learn so that future administrations can do better. And I think if we take that approach moving forward, how do we try to do better in the future versus how do we try to point fingers looking backwards? I think we'll be in a better situation. There's the saying that the windshield on your car is bigger than the rearview mirror for a reason. You're supposed to spend more of your time looking forward than looking backwards. We are spending a disproportionate amount of our time, particularly going into another election year, looking in that rearview mirror. And if we do that, the car is going to continue to run off the road and into a tree. That's what we see happening.
Yep. Excellent message. And I very much enjoyed the book. I encourage everybody listening and watching to pick up a copy. Dr. Adams, I just really appreciate your time today. Again, I'd love to have you on for a follow-up because there's so many other topics we could get into. But again, for everybody who is going to be listening across the various podcast networks or watching on our YouTube channel, again, you've been spending time with the 20th Surgeon General of the United States, Dr. Jerome Adams, also Presidential Fellow, Executive Director of Purdue's Health Equity Initiatives, Distinguished Professor of Practice in both departments of Pharmacy Practice and Public Health. And go out there and pick up a copy of Crisis and Chaos, Lessons Learned, Lessons from the Front Lines of the War Against COVID-19. Dr. Adams, I want to thank you again for taking the time out of your schedule. Obviously, thank you for everything you've been doing throughout your career for public health. And as we like to say here on our show, thanks for helping to create a better tomorrow via what you do and your insights. A really great story. And so honored to have you on the show.
Thanks so much. The pleasure is all mine. And Happy New Year to everyone. Resolve to be a better you moving into the new year. Recognize your political biases. Realize that the only way forward is together.
Outstanding. Be well.